thank you naman at nakaikot tayo dito. Ang ganda ng lugar.
No, ang ganda talaga mga equipment. Ngayon na tayo nakapasok.
Mas na-appreciate ko siya kasi the first time I was here, maraming tao.
During the inauguration,
Yes.
no? I think this was inaugurated noong September 20.
Yeah.
Tama?
Kaya ano yung January daw?
Parang soft opening niya.
So
Yes,
the
the open
students were
days.
used.
Tapos pero yung formal inauguration happened.
Ayaw may piya kayo tayo na yung
Yeah,
September.
wala tayong idea na yung class project pala natin ganito kaganda.
Yeah.
Kasi we contributed to this.
At least ganito, no? You know where your money went.
Tsaka napakaganda kasi it's something na hindi natin na-experience.
This is something new, groundbreaking for the
Innovative. I mean, it's a new way of teaching, so it challenges us, the faculty, also to learn at the same time, so be learners also with our students.
Paano ba tayo natuto ng skills? Sige nga, paano?
Sa tao na
So
sa
you want to do one and teach one.
Yes.
Sa actual person.
Yeah.
Samantalang dito, pwede na nilang practicein yung skills sa mga mannequins na ang gaganda.
So yung refinement, yung like techniques, yeah.
So lesser
Very
ang
nice.
possibility of injuries.
morbidity.
Kaya nga, actually, nung nalaman ko na pang clinical simulation lab yung project natin, I was really very happy na it turns out na napakaganda ng mga contribute natin sa college.
Alright, so Leonard, we came from the OR setup now. So here, we're in the task trainers room where students can practice already the different procedures like IV insertion, breast examination, blood extraction, and also pelvic exam and catheterization.
May circumcision din.
Ayun, nandun yung
Yes.
circumcision.
O di ba?
Yeah.
Nahirapan ka nga dun sa retroverted, ano?
Yeah, nung tinry ko kanina, muntik pa ako mapahiya.
So yeah, so aside from that, there's also a childbirth sim area where patients can, let's go over there.
Okay. Ito yung favorite room ko out of all the simulation rooms kasi this is the OB room. And ito si Lucina, the model for the normal delivery, right? At ito yung baby niya. May pangalan ba yung baby niya?
Wala, Lucina, baby.
Bigger.
Ang galing, no? The students can actually
Gumagalaw ang patara yan!
They can actually simulate childbirth dito. No?
Yeah.
And all the other drills.
All the maneuvers like shoulder dystocia, do vacuum extraction,
Breech
forceps.
delivery.
Yeah.
So for both normal and abnormal situations, emergency.
Yeah.
Yeah, so we
galing,
can
no?
ask the professors, the doctors to give a scenario that they want simulated. So they also have modules for postpartum hemorrhage, for uterine atony and uterine inversion. So yeah.
Tapos yung SimTech, i-input nila yan dun sa computer. Tapos yun ang gagawin ng
Kailangan the consultant should be very detailed para alam ng mga bata kung how to approach these emergencies or whatever.
Pero kahit face-to-face na tayo ngayon, mas magandang dito na muna magsimula, di ba? Para parang magaling na sila
Hands-on
pagpunta nila sa
skill.
PGH.
May skills from the examination.
Equate with the skill.
True.
Hindi natin to magagawa without the help of our classmates
True.
who generously gave to this project. Even if we have the slightest idea of what the thing we're supporting was at the time, diba? And moving, as you said, from that medicine building to the Henry C. Medical Sciences Center and to the CSL finally. And we look forward to celebrating with the rest of our classmates for our homecoming this year and celebrating also this achievement of being able to help and give back to the college. Maraming salamat.
Ninulat ang mata sa katotohanan, pinukaw ang damdamin para sa mga aba. Galing ay nilinang talino at kakayahan hanggang sa maging mahusay na manggagamot ng bayan. Itanghal ang ating pinagmulan, pagpupugal sa kolehiyong mahal, paggunita sa ating pinagdaanan, UP Medicina babalikan. May nangibang bansa at doon ay nabilahan, ang iba ay nanatili sa sariling bayan. Saan pa man naroon ay pinagbubutihan, dalang marangal na pangalan, pamantasan na hinirang. Itanghal ang ating pinagmulan, pagpupugal sa kolehiyong mahal, paggunita sa ating pinagdaanan, UP Medicina babalikan. Itanghal ang ating pinagmulan, pagpupugal sa kolehiyong mahal, paggunita sa ating pinagdaanan, UP Medicina babalikan. Paggunita sa ating pinagdaanan, UP Medicina babalikan.
Pagpupugay at paggunita.
Pagpupugay at paggunita.
Pagpupugay at paggunita.
Pagpupugay at paggunita.
Panginoong Diyos, inaalay namin sa iyo ang 2024 bilang taon ng aming pagpupugay at paggunita.
Naway maging pagpupugay sa UP College of Medicine.
Ang lahat ng aming hinandang pagtitipon at pagkikita-kita. Kasama na ang iba pang aktibidad katulad ng webinars at postgraduate courses.
Sa aming paggunita at pagpapasalamat sa kolehiyong mahal.
Ugawin mo ang aming puso at isipan na handang tumugon
upang mapagsilbihan ang lahat ng nangangailangan
At may sakatuparan ang aming kagustuhan at hangarin.
na
makapaglungsad ng mga proyektong pamamayanan.
Bigyan niyo po kami ng oras, kakayanan at kagustuhan
Na makilahok sa mga gawaing itinakda sa pinagpalang taon na ito.
Isinasamo namin sa iyo na maging matagumpay.
Makabuluhan, kapag-ipakinabang at masaya.
ang lahat ng mga aktibidad ng mas katugmasa para sa taong 2024.
Paspasan mo ng iyong mapagpalang kamay.
Ang bawat alumni na buong pusong naglilingkod
At nag-aalay ng kanilang oras, talino, kakayahan.
Kasama na ang mga nagbigay ng tulong pinansyal na higit pa sa pinansyal.
upang maging maayos at mahusay ang aming pagdiriwang.
Pagpalain mo pa ang lahat ng kasapit ng UP Medical Alumni Society.
Pati na rin ang mga miyembro ng UP Medical Alumni Society in America.
Upang makatulong ang lahat ng alumni sa pangangailangan
ng aming pinakamamahal na UP College of Medicine.
Ang lahat ng ito'y idinadalangin namin sa aming kagustuhan na ikaw ay papurihan, O Diyos, magpakailanman. Amen.
We would like to ask everyone to kindly turn off your microphone and video. Please type your questions in the Q&A chat box. We will try to address all of them in the open forum after the presentation. Evaluation and post-test questions will be available for 30 minutes after the initial broadcast. A certificate of attendance will be emailed after the evaluation and post-test are completed.
Good afternoon, everyone. Welcome to all our participants, classmates, friends, colleagues, teachers, and faculty who joined our webinar today. We thank you for supporting our project, Bridging Gaps, which is part of the UP Med webinar series for 2024 and organized by the Silver Jubilarian class of 1999. I'm Dr. Lina Rose A. Alcances, a member of UPCM class of 1999. I am an otorhinolaryngologist and head and neck surgeon and an occupational health specialist at the Energy Development Corporation. I will be moderating today's session. Before I introduce our speaker, we'd like to remind the audience that you can type your questions about the topic in the chat box even while the lecture is still ongoing. Lower back pain is a common condition affecting a lot of people, young and old. Its causes are myriad, including poor posture, heavy lifting, and improper exercising. Our speaker for today will discuss techniques and activities that we can do to help prevent back pain. Today's speaker is Dr. Dave Anthony G. Dizon. Dr. Dizon is an orthopedic surgeon who specializes in spine surgery. He got his Doctor of Medicine degree from UPCM in Manila through the Intermed program. He took his residency in orthopedics at the Philippine General Hospital and his spine fellowship at the Klinikum Karlsbad Langensteinbach in Germany. He got his bone and cartilage transplantation and joint revision surgery fellowship at the Brisbane Private Hospital and the Queensland Bone Bank. Dr. Dizon is presently a medical specialist 3 at the Department of Orthopedics at the Philippine General Hospital. To give a lecture entitled, I've Got Your Back, Lifestyle and Low Back Pain, everyone please welcome our kilabot ng Ward 8, Dr. Dave Anthony G. Dizon of UPCM Class 1999.
Hello, good afternoon, Rose. Good afternoon,
Good
everyone.
afternoon, Dave.
Okay, let's just get this set up. Here we go, share. Okay, so I was tasked to talk about lifestyle and low back pain. Since today's webinar is not sponsored by industry, I have a bit of freedom to talk about how it really goes in terms of treatment. So I have no financial relationships. Today we'll be talking about the data on low back pain, review the risk factors, review the natural history of back pain, and discuss the principles of treatment. I believe that if the patient is able to understand exactly what's happening to his or her back, then that patient can help the physician in treating the back pain. So you really have to understand what's going on, and I'll try to help you to walk you through it. Back pain is a very common problem. The lifetime prevalence is up to 84%. And after an initial episode of lower back pain, about 44 to 78% of people will experience a relapse. and almost 40% will have relapses of work absence. And this is one of the more common patients that we see in the clinic. Young adult, office worker coming for lower back pain, usually insidious in onset, so 2 weeks, maybe a month. Usually there's no recalled history of trauma. Sometimes the patient might say may nabuhat siya or nakaupo lang siya na matagal and then sumakit na. And more often than not, it's relieved by rest. On physical examination, it's generally unremarkable. You won't find any neurologic abnormalities. The lower back muscles will usually be tense, and you may or may not have any tenderness or trigger points. And the thing is, 85% of patients with isolated lower back pain cannot be given a precise pathoanatomical diagnosis. There is no gender predilection. And people in their 3rd to 5th decade of life will usually experience this. It's the most common cause of work-related disability in people below 45 years of age. And even among healthcare workers, it's very common. In Belgium, of 305 health workers coming for consulting for a musculoskeletal disorder, about 72.4% will be due to lower back pain. Same with the Chinese. About 60.3% of healthcare workers consulting for a musculoskeletal disorder will have low back pain. In Malaysia, it's the same thing. Cumulative life prevalence, about 72.5% with a yearly prevalence of 56.9%. The usual factors would be, it would depend on the professional category, whether you're talking about a nurse or a physician. Bad body posture, lifting heavy objects or patients, and the increased levels of lifting. And also there's the psychological aspect to it, the job dissatisfaction and stress. In Saudi Arabia, again, very similar numbers, 74.2% prevalence of lower back pain among healthcare workers. The reasons enumerated in this series, again, it's lifting, rotating the torso while bearing weight. I'll be talking about that later on. Transferring patients onto a bed or chair. So again, it has something to do with lifting, pulling a patient up on the bed. Again, lifting, repositioning a patient in bed. So again, lifting. In India, in this particular study, they saw that the highest risk was in nurses because nurses tend to have a more physical job in the hospital. Lowest risk was in physicians. And the reasons given, again, were working in the same position for prolonged periods or working in awkward or cramped positions. Also handling an excessive number of patients or samples in a day. And to be able to diagnose, of course, very critical is your proper evaluation of these patients. And according to Steve Jobs, if you define the problem correctly, then you almost have the solution. So it's very critical. And this rings true also for low back pain, because with your focused history and PE, you should be able to differentiate what kind of pain your patient has. Are you talking about non-specific lower back pain? Does the patient have a radiculopathy? Does it radiate to the lower extremities? Are there other specific spinal causes for the back pain? So in other words, are there any red flags? So red flags are specific aspects of the history in PE which may suggest a serious underlying condition which is causing the back pain. So you want to rule out signs and symptoms of trauma, of infection, or of cancer. Of course, you also have to consider the so-called yellow flags, so the psychological aspect to it. Patients with unstable personalities, those who may benefit from secondary gain, because this will have relevance on the chronicity of the pain and your outcomes in terms of treatment. And once you've done a proper history and physical examination, you can come up with a differential diagnosis. And if you diagnose your patient with mechanical back pain, you'd be correct 97% of the time. Okay? So referred pain from the viscera it's actually not that common, about 2%. And non-mechanical back pain is 1%. And that 1% actually comprises of the entities which patients are usually most afraid of: cancer, neoplasia, inflammatory arthritis, infection. So these three are actually not that common. So in that 90% of low back pain, about 3/4 of patients will be coming to you because of a lumbar strain or sprain. So the usual run-of-the-mill lower back pain. And the other quarter, it's divided among herniated discs, stenosis, age-related degeneration, fractures, deformities. Okay, so it's very common. Muscular back pain, mechanical back pain. And the reason for this is a lot of people really overlook the fact that the spine, a lot of people attribute their back pain to the spine, but the spine is really just a scaffold. It's where most of the bones are attached, and all of the ligaments attach each bone to each other, and it's also the attachment or your scaffold for your muscles. And more often than not, the back pain is due to either a sprained ligament or a strained muscle. And the reason for this is actually very easy to understand. So if you were to draw the so-called plumb line from C7, which denotes the center of gravity, as a person bends forward, that also moves forward. So the weight of the body is actually in front of the spine. And the easiest way to understand this is to think of the spine as a crane. So you have your spine as that post, and you have your center of gravity right in front. But to counteract, to balance everything, you need a pull, a counterweight at the back. And that counterweight actually is the pull of your muscles. Okay, so what happens if you lift something heavy or you gain weight? That means that to counteract that increase in weight, there has to be a greater contraction of your lower back muscles. If that center of gravity moves forward, so if you bend forward, or something as simple as really bad posture, so you're slouched forward, there is no way for the back muscles to move backward, right? So it has to increase the tension. And more often than not, that's how you strain it. If you repetitively add strain on the lower back, eventually, may bibigay, may sasakit. Okay? And your core muscles and all of the muscles in your pelvis, you can feel it anywhere around these areas. But which brings us to the next question. A lot of patients come to the clinic with back pain, and sometimes they ask, do I need an x-ray already? And according to the clinical practice guidelines of the American College of Physicians and the APS, you really do not need to obtain imaging or other diagnostic tests in patients with non-specific lower back pain. Okay? You only need to do it if you have neurologic deficits or if you detect red flags. So that's the only instance when you need to do x-rays at the outset. And the reason for this is there is a very significant false positive rate. So in this study by Boden on asymptomatic subjects, they did an his group did an MRI on 67 asymptomatic subjects. So walang kahit na anong nararamdaman. And you can see here, in the 20 to 39 age group, 21% will have findings of a herniated disc kahit na walang ibang nararamdaman yung patient. And as the patient population is older, the findings actually increase. So disc degeneration, 34% below 39 and below, 92% in the 60 to 80 age group. So the false positive rate is actually very high. And if you see these findings, it does not necessarily mean that there is pain, and it will just confuse the physician even further. And even looking at other imaging modalities, discography, myelography, CT, MRI, the prevalence of IV disc herniation by itself is actually very significant, even if the patient is asymptomatic. Okay, so which brings us back to that differential diagnosis. 97% of patients will just have simple mechanical back pain, of 3/4 of which are really just due to muscular strain. So imaging is not necessary during the first 6 weeks if red flags are not present and your patient is between 18 to 50 years of age. After 6 weeks, usually a plain epilateral X-ray is sufficient. And you'll find this recommendation in most clinical practice guidelines on lower back pain. So with a simple X-ray, you'll be able to rule out already most of the problems, which if most of the osseous issues with back pain, like if you're entertaining for instability, for instance, or if you have a compression deformity, like in this case, you'll be able to find that and rule it out. Now, this is one diagnosis that this is one sentence that incites a lot of fear in a lot of patients. They have an X-ray done, and the radiologist will put in their official reading predisposition to lumbar instability. And the patient runs to the clinic scared. Is my spine unstable? Can I get paralyzed? So the patient's usually very alarmed. And all that the radiologist means when the radiologist makes that reading is if they drop a plumb line from L3, it should fall just at about the area of the sacral promontory. If that plumb line moves forward, then that is predisposition to lumbar instability for them. So essentially, it's just a sagittal alignment issue. It has nothing to do with biomechanical or clinical instability, not in the orthopedic sense anyway. So it's a wastebasket diagnosis. And this is another issue that I get. Patient comes to me with an X-ray. Doc, may scoliosis yata ako. Doc, may nakitang scoliosis on yung screening na chest X-ray ko nung nagpa-medical ako. And so the scoliosis have anything to do with back pain? But just as in the general population, yes, patients with scoliosis can have back pain, but the reason for the pain is actually the same as in the general population, which is muscular strain. And in fact, pain does not seem to be an issue for the majority of patients with scoliosis. There are even studies which show that there is no correlation between the size of the curve and the back pain. The correlation is actually more between the patient self-image and back pain. I get a lot of patients who complain more of back pain who have mild scoliosis compared to those who have really bad scoliosis. They rarely complain of pain. And this is another question that I get. This is another statement that I get from patients. Doc, may slip disc ako. And they're usually diagnosed by any number of ways, whether just on a plain X-ray or they have an MRI with that kind of a reading. So you have to understand, how does a slip disc occur? Alf Nakemson cited a study that was done back in the 70s where they placed pressure electrodes in the discs of volunteers, and they measured the increase in the pressure in those discs on different positions. So patient standing up is the default setting. When the patient reclines, the pressure decreases by 50 to 80%. Now, with unsupported sitting, let's say on a stool, that increases the load on the L4, L5 disc by up to 40%. With forward leaning, and especially if you carry a weight, this increases the disc pressure by about 100%. And it becomes even worse with forward flexion and rotation, where the disc pressures actually can go as high as 40%. So you can imagine, if you do this repetitively over the course of several months or several years, eventually your disc might tear. And this is a cross section. You can actually see that the disc is very highly innervated. So if you get a tear, it will irritate those nerves. And initially, it can present as back pain. But eventually, with the inflammation from that tear, it will recruit inflammatory chemicals, which will irritate the nerve, and eventually you will have a chemical radiculopathy. Eventually, the nucleus will leak out and pinch on that nerve. And it's as the evolution proceeds, it will evolve from lower back pain to actually shooting pain down whichever nerve is being pinched. And you develop what laymen would term as sciatica. So essentially, it's pain radiating down the entire sciatic nerve towards whichever specific nerve region that nerve root is innervates. Okay, and so we move on to treatment. The natural history, when we talk about natural history, we're talking about what will happen if we don't do anything about the pain. We just let it run its course. About 90% of patients seen within 3 days of onset and treated usually improve within 2 weeks. But regardless of whether you treat this patient or not, 80 to 90% of attacks will recover within 6 weeks. So it's very benign. Okay. And that forms the basis of the recommendations of this clinical practice guideline from the American College of Physicians. So given that most patients with acute or subacute lower back pain improve over time, regardless of treatment, the first treatment option that you should think about is actually non-pharmacologic management. So you can try heat, you can try massage, acupuncture, maybe even spinal manipulation. But if the patient is in a lot of discomfort and you feel that pharmacologic treatment is needed, you can just use the usual non-steroidal anti-inflammatory drugs, NSAIDs, or skeletal muscle relaxants. Okay, so for acute low back pain, what is recommended by that CPG are NSAIDs and SMRs. Before, they would say paracetamol is a good first option, but there was a recent RCT where they showed that there was actually no difference in effectiveness versus placebo. For chronic lower back pain, again, NSAIDs is first line, followed by your opioids and then duloxetine. However, for chronic back pain, first line of treatment is still non-pharmacologic management. So exercise, multidisciplinary rehab, acupuncture, stress reduction, etc., etc. So it's only when this does not work that you actually think about doing pharmacologic management. And you will notice whether for acute or chronic back pain, there's an increased emphasis on non-pharmacologic management. So what does that mean? For acute, heat wraps, massage, acupuncture, manipulation. For chronic, exercise. So different variations of exercise, rehab, even going as far as cognitive behavioral therapy. So one treatment option that some patients ask about is, do I need to do bed rest? Do I need to be confined at home? And based on this Cochrane meta-analysis, they found out that in patients with low back pain or even sciatica, bed rest does not relieve pain better than advice to maintain regular activity as long as it's not very strenuous. In fact, bed rest can actually lead to a decrease in function. And in this RCT, in patients with acute lower back pain, 4 days of bed rest was no more effective than continued normal daily activity at 1 week or at 1 or 3 months. So as long as the normal daily activity is not too stressful for the patient can just continue whatever he or she is doing. Physical therapy is better than medical care alone over a 6-month period, especially when the program is medically supervised. So that's where people like Dr. Jenny Young comes in. Physical medicine and rehabilitation plays a big role in this kind of treatment. It's actually better than chiropractic manipulation for the treatment of chronic pain. And what works? Heat in general is recommended, and that's a Cochrane review. Cold has equivocal evidence. Tense and traction will not change the natural history. Patients will ask, do I need to wear a corset or a back belt? So there is evidence for its use as a preventive measure in patients with in occupations with heavy lifting, but in general, it's not really recommended other than for that purpose. Shoes and insoles, equivocal evidence. Exercise, definitely for lower back pain, but for acute, you'd want them to rest. Back schools, again, good for chronic. For acute, you just want them to rest. Alternative medicine, manipulation, chiropractors. So yes, there is evidence that they can help with acute lower back pain with no radiculopathy. But take note, chiropractors are not licensed by the PRC in the Philippines. So that's a very big question mark in our setting. Massage, effective for subacute and chronic. Acupuncture has been proven for chronic, equivocal evidence for acute back pain. And after all of that, at the end of the day, you have to try to find out what is causing your patient's pain. And this is something that I tell all of my patients. No matter how much meds you take, no matter how much physical therapy you do, if you're not able to identify what is causing your pain and it's still there even after all that treatment, chances are the pain is still going to be recurrent. So you have to look at your lifestyle factors: poor physical fitness, smoking, anxiety, depression, stress. Occupational factors, bending or stooping. If your work involves bending, stooping, twisting, prolonged driving, heavy lifting, prolonged sitting, vibration exposure, these are all risk factors for back pain. So some of my golfer friends, Dr. Alan Reyes, you might not like to hear this, but yes, golf is a risk factor for back pain. Tennis can be a risk factor because you have a lot of explosive rotation there. Gymnastics, the young teenage gymnasts will not feel it, but once they're older, they're going to feel it. And I'm sure Jenny tackled this in her lecture last 2 days ago. So the more that you bend forward, the greater the pressure on the neck, and that also goes the same as for the lower back. High-heeled shoes. If for the women who like wearing high-heeled shoes or those who have to wear it, like I get patients who are hotel receptionists where it's part of the required dress code. They can get back pain, especially if they have to stand on it for a long time, because it changes the sagittal balance of the spine. It changes the sagittal alignment. It changes the way the person walks. So if it changes your gait, it changes your balance, at some point, it's going to cause back pain. Prolonged standing, and in general, being in a single position, whether it's standing or sitting for a long time, and the definition of prolonged is anytime more than an hour. This is a risk factor for lower back pain, because you have to imagine, if you are in a single position, whether you're standing or sitting down, only a specific group of muscles are working. So the other groups are not. So the equivalent of that is, my favorite analogy for that is you own a 7-Eleven and you run 3 shifts, morning, afternoon, and night. If you run your 7-Eleven with just the morning shift, so hindi mo ginagamit si afternoon and si night shift, at some point, magwewelga yung morning shift kasi sobrang pagod na sila. Sila lagi nagtatrabaho the whole time. And that's back pain for you. So sitting and occupational back pain. Sitting by itself, actually, according to this systematic review, is not a significant factor for back pain. But if you add vibration or awkward or poor postures, then it increases the chances of occupational back pain significantly. So some authors attribute it to the change in lumbar lordosis. So supposedly with when the patient is standing, the lordosis is greater than by about 50% compared to sitting. So this is another study on 30 male volunteers where they did x-rays of a patient standing and at different positions of sitting. And they found out essentially that sitting with in a chair with 90 degrees is actually gives the best lordosis rather than those ergonomic chairs, and especially with all of these other variations where the back is unsupported. And that's the problem also. We've seen an increase in back pain during the pandemic when people were forced to work from home and their working conditions were not really ideal. So is there really evidence for ergonomic chairs? So in these systematic reviews, they actually did not find any significant evidence. It's very limited. So you can have a simple dinner table chair and which you sit on properly, and you might still have with good posture, and you might not end up with back pain. So what you would want is a chair with an adjustable backrest so that you're able to sit with your back straight, your hips 90 degrees, and your knees close to 90 degrees. Laptops are very notorious for back pain because, as you can see here, especially if you're on a regular household chair, the person is actually stooped forward significantly. That places a lot of strain on the neck area and on the lower back. Even if you use an ergonomic chair, the person is still stooped down just to check out that screen, and that places a lot of strain on the back. So one recommendation if you have to work on a laptop is to get a laptop stand or place your laptop over several books until your screen becomes more or less eye level. You want to simulate more or less a desktop so that you're sitting up properly and your eyes are actually what you use to scan the screen, okay? But if you're using a laptop, you need an external keyboard and a mouse so that you'll be able to still work properly with your elbows at 90 degrees. So sitting at home, again, you need a good chair, good backrest. The depth should not be too low, and there should be enough clearance for your knees. Sitting, driving, again, you should be able to adjust the car seat such that you're just slightly reclined, okay? Make sure you have good lumbar support and you're able to reach the brakes and the accelerator properly. A good bed. This is another question that I get. What is the ideal mattress? So patients would say, Doc, I have an orthopedic mattress at home. But what is an orthopedic mattress? If you check out most stores, even if you ask for an orthopedic mattress, there are several grades to it in terms of stiffness. Most studies would recommend a medium firm grade for the bed. That would be ideal for your back. Just enough for the normal curves of your back to sink in, but with still enough support for your lower back. So if you have back problems, the ideal way of getting up would be to turn to your side and lift yourself up using the weight of your legs and pushing yourself up with your elbows so that you minimize the pressure on your lower back. If you are a side sleeper, ideally you'd want to have a pillow which is just tall enough so that your head is still in a neutral position with your body. This is actually not completely correct. You'd want another pillow here between the arms so that your upper body does not twist, and another pillow here between the legs so that your hips don't adduct too much, at least the upper hip. If you have sciatica, it would be good if you place a pillow just underneath your knees like this. So this helps to relax the sciatic nerve, or even if you have spinal stenosis, it helps to open up the lower back so that you decrease the pinched nerve symptoms. So when is surgery needed? So to put it simply, if your pain is being caused by a significant deformity, or you have stability issues, and especially if you have neurologic issues, then maybe at the discretion of your doctor in after a lengthy discussion with you, then surgery might be an option. So in general, it would be failure of conservative management. You've done everything, but still after more than 6 weeks, pain is still very significant. if your ADLs are already affected, if you have neurologic deficits, and especially if you can identify the actual pathology which is causing the pain. Because if you cannot identify the pathology which is causing the pain, you might just end up with even worse problems, what we would term in spine surgery circles as a failed back. So, to summarize, back pain is a very common problem. A thorough history and physical examination are still the gold standard for diagnosis. Always be on the lookout for red flags, especially neurologic issues. In the absence of red flags, diagnostic workup is not immediately required. Both pharmacologic and non-pharmacologic therapy are options for the treatment, but there must always be emphasis on non-pharmacologic management as the first line. And then lifestyle changes and exercise are needed for long-term control. And that's it. Thank you. So I'll be happy to entertain any questions.
Thank you, Dr. Dizon, for that very comprehensive and a good mix of practical and yung conceptual na basis. I'm sure marami kang napasaya ngayong araw na to. At this point, we'd like to thank our sponsor, a generous classmate who wants to remain anonymous. So the floor is now open for questions from our audience. There are several questions I'm seeing. Please type in your questions in the Q&A box in the lower edge of the Zoom screen or in the comment section for viewers of Facebook Live and UP Manila live stream.
Okay. Yeah.
Ready ka na ba?
Well, since there are only a few questions so far, I'll answer it live. So, from anonymous attendee at 12:20 p.m. What care should be given to those with scoliosis? Are there movements or activities that should be avoided? In general, my patients with scoliosis, especially those with mild to moderate scoliosis, and to a certain degree, even the severe types, I treat them as normal. I don't really, I encourage them to be as active as possible. They actually need it more than regular people because of the muscular imbalance due to the scoliosis. The muscles have to be well exercised so that the chances of back pain is decreased. Are there movements or activities that should be avoided? In general, not really. If you listen to my lecture, you know more or less what to avoid because it's very similar. The cause for back pain for scoliosis is the same as in the general population, which is muscular strain. So if you know how to prevent muscular strain, it's pretty much the same thing.
Dave, you mentioned in your lecture there are parang sports activities that predispose someone to back pain, like yung golf and tennis ba yun, and gymnastics. Are those contraindicated for those with scoliosis?
Case-to-case basis. I just tell there are some people who have it and who really want to do it, especially golf. Like I just tell them, if you want to do these kinds of activities, I'm not going to stop you because for me the exercise actually does a lot more. There's a lot of value to it. I just tell them, you're not going to go for that hole in one. Just be happy that you can play lightly, play for leisure. Don't be too competitive. Yes, same with tennis. You want to do tennis, fine, wag ka magpakamatay sa bola. Just play leisurely, or yun, you can, if you supposedly that's where pickleball comes in, diba?
Ganun ba?
Much lighter.
So pickleball is recommended.
It's a lighter version
Okay,
supposedly
so
it's designed for people with bad backs, for elderly.
I think it's kinda parang counterintuitive because some people think na masakit yung likod ko, kailangan ko magpahinga, diba? Na hindi ako masyadong gagalaw because it might aggravate. Pero hindi pala.
That's true for acute low back pain. But for chronic, you actually need to strengthen your core. And you can only do that with exercise.
And even before you have any pain, it's always a good
yes, prevention is always best.
To strengthen, especially some of them who are in that age group. Them, not us. Sige. Okay,
so there's another one here. Can a pinched nerve heal on its own? It depends on what's causing the pinch. Okay? If we're talking about a slip disc, a disc herniation, there are actually studies that show that the body can absorb that disc and take away the pinch. Problem is, it takes an average of 3 to 5 years for that to happen. So if you can wait it out, then fine. We can just continue with pain management, physical therapy until everything settles down. And I've had patients who've decided to go along that option. But there are some patients na nagmamadaling gumaling. The most predictable pa rin talaga is surgical excision.
Okay. There's
Yeah.
a comment here on opioids. Sabi niya,
Yeah.
technically opioids are not advisable daw. I'm not sure what the context here
Well,
is.
in general, if you can avoid it, so much the better. That's why NSAIDs are still first line. Eh. But if you go with the WHO stepladder, if you yung stepladder protocol of WHO, first line is paracetamol, then NSAIDs, and then you go to opioids. So depending on the level of pain. So sometimes if you're not able to really address the pain properly with the usual with the first line, then you move on upwards. But yes, technically, if you can avoid opioids, so much the better.
Better, oo. And that's regardless of what is causing the pain. So parang ito, kinwalify niya for chronic non-malignant pain.
Yeah.
Generally. But for if there's any, yung sa 1% that you mentioned that might be malignant.
Well, yeah, I mean, let's say if you're talking about pain from cancer, from spinal metastasis, I mean, that's a different animal altogether.
Alright. So iba yung approach, or do you still go through the step ladder of
It's the step ladder.
Okay.
Yeah, I mean, if it will be addressed by just, let's say, nawawala pa, sometimes nawawala pa rin sa paracetamol, sige, fine, di ba?
Even if it's malignant.
Sometimes, not always, but I've seen patients na ganun.
Right. So it's always a case-to-case basis, in short,
Yeah, case-to-case basis.
Okay.
Best thing to do for post-pregnancy back pain. Post-pregnancy back pain. In general, back pain during pregnancy is due to two things. Number one, muscular back pain, because you have that added weight of your baby. Number two, for your pelvis to open up, your body enters a general inflammatory state. Diba? It's inflammation which opens up your SI joint so that your symphysis pubis also expands. And sometimes that can lead to sacroiliitis, so inflammation of the SI joints. So case-to-case basis, your doctor has to assess properly why there is still persistent back pain after you've delivered the baby, and treat it accordingly. If it's muscular back pain, then that should disappear with, I mean, it should get better with pain management and physical therapy and eventually exercise. If it's sacroiliitis, there are other options for that also.
Okay. Thanks. We have a couple of questions from Facebook. Actually, madami, no?
Yeah.
Some of it I think have already been answered, but here's
Sige, I don't see my Facebook.
Yeah. There's a question on the mattress, which you talked a little about earlier. But do you recommend mattresses with memory foams?
Memory foam is okay, but bottom line, there has to be, and it has to be stiff enough. It has to be soft enough to accommodate, so that because if you look at your spine on the side view, your spine is not straight. Okay? On the side view, you have the curve of your upper back, and then what we call the small of the back, sa lower back area, it curves, there's another curve. So those curves have to sink into the mattress. So some memory foam is very generic in the sense that you can have it can be too soft, but then again you can have that really good
firm na memory
sweet spot na you have enough support but just enough softness. So that's what you want. If we're going to talk about grades kasi, the recommendation is for a medium firm, regardless of what kind of mattress. If you're getting those spring mattresses, memory foam, or regular foam mattress, that's what you want. I'm just not sure kasi if the foams that are sold in the Philippines, especially the locally made ones, are graded
Ah.
using yung international criteria.
Yeah.
So I don't know. I'm not sure about that.
Yeah. So it's not automatic na basta sinabing memory foam, that's automatically better for you, diba?
That's so generic eh. Memory foam, orthopedic bed. I've seen orthopedic beds which are very, very stiff. I've also seen memory foam mattresses which are too soft.
Okay. Which is not good.
Which is not good.
Either. There's a question from FB on chiropractic therapy treatment. I think you also mentioned this a bit earlier. Question niya is, do you recommend?
It's a qualified answer.
Okay.
Because, like I said, there are studies which show that it can help with chiropractic treatment can help with acute back pain. Problem is, in the Philippines, chiropractors are not regulated by the PRC. So there's a problem. There's that question of quality control. How do you know that your chiropractor is qualified? How do you know that your chiropractor actually finished yung course?
The necessary training.
Yeah, the necessary education for a chiropractor, or pumunta lang siya sa University of Recto.
And got a certificate.
Yeah.
So it's the quality that might be
It's the quality. And it's dangerous if you go to someone who does not know what he's doing and he starts cracking your spine. I've seen patients na who only had back pain as an issue, and then she had her neck cracked kasi nabudol siya ng chiropractic management ng kaibigan niya. Came back to me with a cervical radiculopathy. Nagkaroon ng slip disc siya.
Oh no, okay.
Yeah.
Just because of that, So dapat careful.
We also had another patient in PGH who supposedly had chiropractic manipulation of the lower back, but the chiropractor did not work the patient up properly. Yun pala, the patient had Pott's disease, TB of the spine.
Okay. Which chiropractors won't be able to diagnose, right?
Well,
Tama ba?
In the US and Australia, they do x-rays. They work the patient up properly.
Because the practice is regulated there.
It's regulated, yeah. So they can make prescriptions, they can request for x-rays. Here, you cannot request for an x-ray if you're not a doctor or even a dentist. Diba? Dentists can prescribe x-rays of the teeth. But if you're a layman, you cannot. So that's where the problem lies. Yun. If there is an unrecognized issue, kasi that's another thing. Even in the US with licensed chiropractors, let's say for neck manipulation, chiropractic manipulation of the neck has a mortality rate.
Mortality rate?
Yeah.
Nakamamatay?
About 1%.
Oh my.
Yeah, they attributed it to with manipulation of the neck. If there is a spur just right beside the vertebral artery, when you do the manipulation, that spur might lacerate the vertebral artery and cause a stroke.
Right. Okay. So it's possible in 1%. So yun, I guess it's it's less about the practice of being a chiropractor, yung the science of chiropractor, chiropractic, ganun ba?
Well,
but
chiropractic
more
yata yung tawag
on
nila,
how it's being done here.
Yes.
Kasi hindi siya regulated.
It's not
so we're not
regulated.
sure.
So that's why it's very difficult for me to recommend because I don't know about the quality control.
Yeah. So just be aware for our our audience. One more question here in Zoom I'm also interested.
Yeah.
In your practice Dave, have you ever encountered may relationship between endometriosis and lower back pain?
Yes, I actually get quite a number of those. Usually the back pain occurs around the time of menstruation. So if I pick that up, I usually refer to my favorite OB. So for evaluation for the possibility of endometriosis. So yes, it can happen.
Okay. So pag ganun, it's more of an obstetric, OB-GYN, issue
Yes,
rather than,
OB will have to address the endometriosis to control the back pain.
because that's a cause.
Yes.
Oo, sige. Alright.
What
Sige, ang
else?
daming
Here,
chiropractic.
efficacy of Celtican in the treatment of lumbar radiculopathy. In general, vitamin B and all its variants has not been shown to control pain. So it's not really used for the treatment of pain. It's supplement.
Okay. Sige.
Yeah, so there's no evidence for vitamin B and all of its variants to control pain.
Okay.
Effectiveness of Williams flexion versus Mackenzie depends on what you're trying to address. So that's maybe when you talk to your rehab, you can ask. Yeah. Anything else that has to do with back pain?
Last question na.
Yeah.
Sige, let's select. Ito na lang, because in part of your talk, you said that most commonly the pain is caused by muscles.
Yeah.
May question dito is can overactivated back muscles cause low back pain too? Overactivated.
I'm not sure. I depends on what you mean. I don't know. Diba? It's a bit vague. Overactivated, but overuse, yes.
Overuse. Or a
Definitely.
muscle strain,
Yeah,
Yun yung
overuse
one
will
of
cause pain, definitely.
the more common. Okay. All right. Yeah, that was our last question. I apologize for all of the other people asking questions. There's 65 just here on Zoom, but because of the time constraints and we'd like to keep to the schedule, that had been our last question. Thank you, everyone. Thank you, Dave, for enlightening
Thank you,
us
Rose.
with your answers.
Yeah.
Yan.
Thank you, Class 99.
Okay. So in summary, we learned a lot from Dr. Dizon's lecture. Some of the things that we learned is that back pain is 80 to 90% of the time it's a lifestyle issue, whether it is from your occupation or daily activities. But that's the usual root cause. It's more common that way than yung other causes. Also, this one, I'm happy to note that medication and therapy have a role, but really it's the lifestyle changes and exercise that's very important in the management of low back pain. And usually the conservative treatment are actually the first line of treatment once you have back pain. So those are very good points to take note of. Thank you again, Dave, our speaker, for taking time to share your expertise and experience with us despite your busy schedule. And as a sign of our gratitude, we'd like to present this certificate of appreciation to Dr. Dave Anthony G. Dizon. Again, thank you very much. Class 99 is very honored to have you as our batchmate and a speaker in this year's Bridging Gaps, the UP Med webinar series of 2024.
Thank you, Rose. Thank you, Class 99. Sana may kasamang voucher din na discount sa class contributions.
Sige. Okay, yari ka mamaya. May we request our audience to please stay for some acknowledgements. We'd like to thank the UP College of Medicine, the Postgraduate Institute of Medicine, and the UP Medical Alumni Society, and the UP Manila Information Management Service for their support of this webinar series. We again thank our anonymous classmate for this generous donation, without which this webinar is not going to happen. We'd also like to acknowledge our certificates partner for this webinar, Experto. Thank you very much. So this concludes our session for today. I'd like to announce our next webinar. Also very interesting because recently, we realized more and more Filipinos are being diagnosed with fatty liver disease. That's a topic of our next webinar. The title is NAFLD versus MAFLD versus MASLD. In fatty liver, do nomenclatures matter? Our lecturer will be Dr. Mara Teresa T. Panlilio, who is a gastroenterologist and transplant hepatologist. She's presently a clinical associate professor of the Department of Medicine in the UP College of Medicine. Webinar will be on Monday, April 15 at 12 noon to 1 p.m. For those who want to get a certificate of attendance, kindly answer the evaluation form which is shown in the QR code or posted in the URL posted in the chat box. You can access this form in the next 30 minutes. Again, thank you very much to all of our attendees.
Thank you naman at nakaikot tayo dito. Ang ganda ng lugar.
No, ang ganda talaga mga equipment. Ngayon lang tayo nakapasok.
Mas na-appreciate ko siya kasi the first time I was here, maraming tao.
During the inauguration,
yes.
No? I think this was inaugurated noong September 20. Yeah. Tama?
Kaya ano yung January daw?
Parang soft opening yan.
So
yes, the open days. Tapos pero yung formal inauguration happened.
Ayaw may piya kayo tayo na yung September.
Yeah, wala tayong idea na yung class project pala natin ganito kaganda.
Yeah.
Kasi we contributed to this.
At least ganito, no? You know where your money went.
Tsaka napakaganda kasi it's something na hindi natin na-experience.
This is something new, groundbreaking for the
innovative. I mean, it's a new way of teaching, so it challenges us, the faculty, also to learn at the same time, so be learners also with our students.
Paano ba tayo natuto ng skills? Sige nga, paano?
Sa tao na talaga.
Do one and teach one.
Sa actual person.
Yeah.
Samantalang dito, pwede na nilang practicing yung skills sa mga mannequins na ang gaganda.
So yung refinement, yung techniques, yeah.
So lesser
very nice.
Possibility of injuries.
Morbidity.
Kaya nung nalaman ko na pang clinical simulation lab yung project natin, I was really very happy na it turns out na napakaganda ng mga contribute natin sa college.
Alright, so Leonard, we came from the OR setup now. So here, we're the task trainers room where students can practice already the different procedures like IV insertion, breast examination, blood extraction, and also pelvic exam and catheterization.
May circumcision din.
Ayun, and circumcision.
O diba, nahirapan ka nga dun sa retroverted, ano?
Yan, nung tinry ko kanina, muntik pa ako mapahiya.
So yeah, so aside from that, there's also a child birth sim area where patients can, let's go over there.
Okay. Ito yung favorite room ko out of all the simulation rooms kasi this is the OB room. And ito si Lucina, the model for the normal delivery, right? At ito yung baby niya. May pangalan ng baby niya.
Wala, Lucina, baby.
Bigger.
Ang galing, no? The students can actually
Gumagalaw ang bata, Ryan!
They can actually simulate childbirth dito. No?
Yeah.
And all the other drills.
All the maneuvers, like shoulder dystocia, do vacuum extraction,
Bridge delivery.
Yeah.
So for both normal and abnormal situations, emergency.
Yeah, so we can ask the professors, the doctors to give a scenario that they want simulated. So they also have modules for postpartum hemorrhage, for uterine atony, uterine inversion. So yeah.
Tapos yung SimTech, i-input nila yun dun sa computer. Tapos yun ang gagawin ng
kailangan the consultant should be very detailed para alam ng mga bata kung how to approach these emergencies or whatever.
Pero kahit face-to-face tayo ngayon, mas magandang dito na muna magsimula, di ba? Para parang magaling na sila pagpunta nila sa PGH.
May skills pagdating sa PGH.
Equipped with the skills.
True.
Hindi natin to magagawa without the help of our classmates
True.
who generously gave to this project. Even if we have the slightest idea of what the thing we're supporting was at the time, diba? And moving, as you said, from that medicine building to the Henry C. Medical Sciences Center and to the CSL finally. And we look forward to celebrating with the rest of our classmates for our homecoming this year and celebrating also this achievement of being able to help and give back to the college. Maraming salamat.